When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first, you need to find the right team. Start your search with Indeed-sponsored jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Hi, and welcome to the Med Prep to Go USMLE Step 2 podcast. I'm Dr. Raj, quadruple board certified doctor in pulmonary, critical care, sleep medicine, and my favorite, internal medicine. I've been doing teaching and educating for like 20 plus years. I love teaching USMLE, doing internal medicine board review, and all the subspecialty stuff. And before I get started, let me read my mission statement. Our mission statement from MedPrep to Go, our mission to improve medical student wellness and reduce educational debt by providing high quality USMLE questions in an online and audio format, by making medical education material available to study on the go. We strive to give you time back in your day to focus on your health and well-being, and we mean every word of it. So how do we do this on these podcasts? I'm going to read 3 questions from our amazing question bank that we have at medprep2go.com. You can follow along, look at the answers, and check out the website. So today we're going to be doing some hematology. Hematology is totally awesome. It definitely integrates so many different things. Hematology and oncology is always going to be a big part of the USMLE. So today we're going to do questions 1, 2, and 3. So this one's going to have a pediatric feel to it. So all you pediatric junkies are going to love this. It is a 9-month-old infant girl presents to the emergency department with her parents, who are definitely concerned. She has seemed tired and fussier than normal over the past 3 months, and the mother thinks she is starting to develop abnormal physical features, most noticeably a large head. Her mother reports that her pediatrician ordered lab tests recently, which showed a low RBC count. The infant was fine until 6 months ago. Wow. That was a misread. He was fine until 6 months old. I'm sorry. And was meeting all her developmental milestones. She is up to date with her vaccinations. Family medical history is unremarkable. She is mildly tachypnic with normal oxygen saturation. The rest of her vital signs are within normal limits. On physical exam, the infant is noted to have slight pallor. She has frontal bossing, a depressed nasal bridge, and is short for her age. A complete CBC shows severe microcytic anemia. Stop right there. So when I think about microcytic anemias, and for those who listen to my recordings, you know I always love giving extra pearls left and right. So when we have someone who's anemic, I definitely think looking at the MCV, the mean corpuscle volume, is a reasonable first step. When I think that they're going to be a hypochromic microcytic anemia, a low MCV anemia, I always think about the big 4. And what are the big 4 things I always think about, whether we're talking about internal medicine or pediatrics? Yeah, number 1, iron deficiency anemia. Number 2, some kind of thalassemia. Number 3, maybe they have sideroblastosis, which can be induced by many different things, including vitamin deficiencies like B6. It can be induced by lead toxicity. And the last is going to be chronic disease, and maybe chronic disease not so much in a 9-month-old infant, but definitely in the internal medicine world, we think about chronic disease. So with that being said, this 9-month-old has severe microcytic anemia. Further tests are ordered to confirm the suspected diagnosis. They're not going to tell us what they suspect, but I guess they do suspect something. Which of the following results would be expected regarding the most likely diagnosis? All right. So the answer choices are going to be A. Do you expect to see basophilic stiffening on blood smear? B. Hemoglobin electrophoresis showing an elevated alpha hemoglobin protein. C. Hypochromic RBCs with erythroblast on blood smear. D. Low ferritin level. E. A mean corpuscle volume to red blood cell ratio that's going to be less than 13. So with all these things being said, which one seems to be the correct answer? Now, choice A, basophilic stiffening, is very highly associated, at least when I was taking the USMLE, with lead toxicity. The vignette really hasn't been hinting at lead toxicity. It can also be associated with thalassemia, so it's not pathognomonic for lead toxicity. But if you do see it, it really wouldn't in itself hit one way or the other. So I'm not really feeling choice A. B, the hemoglobin electrophoresis, that's really hinting at a thalassemia, which there are certain thalassemias that really kind of are niched to the age of the patient around this 9-month-old. So I definitely feel thalassemia is a good thing to evaluate, and I would order a hemoglobin electrophoresis first in the evaluation of a thalassemia. So I do like B. Hypochromic RBCs really wouldn't hint at one specific diagnosis, nor would erythroblast on blood smear. So I'm not going to pick C. Low ferritin levels. If I was really suspecting possibly iron deficiency anemia as the etiology, then I would go for D, but I'm not thinking this is iron deficiency anemia. And the mean corpuscle volume to RBC count ratio is not something in itself that will give me a very specific diagnosis. So, by default, and given the age of the patient, how they're describing this, I'm going to go with B. Let's get the hemoglobin electrophoresis, and let me check out the right answer, which is correct. So the suspected diagnosis is beta thalassemia, given the age of onset, somewhere between 6 and 24 months. This is when after fetal hemoglobin switches to alpha hemoglobin, there are skeletal abnormalities caused by extramedullary RBC production. Family history, signs of a genetic predisposition to anemia. The signs and tests identify anemia with microcytosis. Beta thalassemia is caused by genetic variants in the HBB gene, leading to reduced production of beta hemoglobin chain and thus an increase in the alpha chain, which is seen on hemoglobin electrophoresis. If both copies of the gene have mutations, it causes beta thalassemia major, and patients often become transfusion dependent. The differential diagnosis of a microcytic anemia should include, as we talked about, iron deficiency, sideroblastosis, anemia of chronic disease, and of course, it says in little parentheses on our website, unlikely because this patient's 9, as well as thalassemias. As I mentioned, choice A is incorrect. Basophilic stiffening may be seen in beta thalassemia, but is also present in lead poisoning. So in itself doesn't differentiate the etiology of this question. Choice C, hypochromic RBCs with erythroblast on blood smear is incorrect. Hyperchromia is a very non-specific sign, as we mentioned earlier. And erythroblasts are immature RBCs, which are often present in cases of severe anemia regardless. Choice D, low ferritin, incorrect. Really, you pick that if you think this is going to pertain to iron deficiency anemia. And choice E, the mean corpuscle volume to RBC count ratio, is incorrect. This represents the Menser index, which helps differentiate iron deficiency anemia from beta thalassemia. In this specific case, a ratio greater than 13 can hint at iron deficiency anemia, whereas a ratio less than 13 indicates beta thalassemia, but in general, it's very nonspecific, and we would not use this in itself to help make the diagnosis. So, well done, everyone. Choice B. So let's do 2 more. We got a 55-year-old woman presents to her PCP's office complaining of generalized abdominal pain and bloating that has been bothering her for the past year. She reports her symptoms are worse, especially after food intake. She also complains of weakness, fatigue, feeling sad on most days. Otherwise, she denies chest pain, dyspnea, fevers, and chills. She lives with her husband of 30 years and denies ever using alcohol, tobacco, or recreational drugs. She has a history of a C-section for her only pregnancy. Her family history is significant for Graves' disease. Her routine labs are as follows. WBC counts 45,000. Did I say that right? That just sounds really, really high. I'm going to take it back. 4,500. See, I'm doing these real time. Hemoglobin is 7.9. MCV is elevated at 119. Platelets are 312,000. Serum iron is 109. B12 is 81, which is low. And the serum folate is 13, which is normal, which is the next best step in diagnosing her condition. So looking at the MCV, and once again, the WBC count is 4,500, which is normal. This 55-year-old has a low hemoglobin. It should be 7.9. This should be up into what? They had 13, 14, 15. So this is low, So we look at the MCV and it's elevated. So this is a macrocytic anemia. And the question is, they already kind of gave the punchline because the B12 is what? Is low. And the folate is what? Normal. So it really hinting at all this, it's really kind of going with, are we evaluating this patient for what we refer to as a megaloblastic anemia? So not all macrocytic anemias are megaloblastic, but definitely B12 induced anemia will give you a megaloblastic anemia, mainly because you're going to see these hyper segmented PMNs if you get a peripheral smear. So what is the next best step in diagnosing your condition? Oh, I haven't seen this in a while. A Schilling's test. Now, Schilling's test is a test that I wasn't even born when it came out. Just joking. But a very barbaric way and time-consuming way to diagnose what? B12. I mean, it's not wrong, but I would never pick it. Doing an EGD with biopsies. I mean, I guess if someone was having like iron deficiency anemia, had peptic ulcer disease, that's not what this is showing. It seems really invasive to go throw a scope in there. There's no signs of a GI bleed or anything. So I wouldn't pick B. C, autoantibodies against intrinsic factor. Well, now we're talking not only is B12 deficiency a macrocytic anemia, macrocytic hyperchromic, it's also megaloblastic. It's also known as what? Pernicious anemia. So look at this. Patient has Graves' disease, so probably has antibodies. And because if someone has one autoimmune disease, they could be predisposed to others. So I really like ordering the serology for intrinsic factor. I like it. Bone marrow biopsy, way too invasive. And E, stool antigen for H. pylori. There's no indication that it is H. pylori, and I don't usually diagnose H. pylori with the stool antigen. Maybe I'll order that for follow-up, and it's not wrong to order it. I don't want to go into this whole GI spiel, but once again, really, there was no dyspepsia, no signs of having discomfort. So I'm not really feeling H. pylori. And of course, just because you have it doesn't mean you'll be anemic. And just because you have H. pylori doesn't mean your B12 will be low. So not the right answer. So I'm going to go with C, antibody. And let me view my answer. All right. For the exact same reasons I told you, looking for that pernicious anemia, the right answer is what? C. Good job, everyone.
In Walmart's Huluville, time was ticking away. Only a few nights left till the big holiday. But last-minute gifters had no need to worry. Walmart Express Delivery got their gifts in a hurry. From Nintendo to Nespresso and Lego Flowers, they could check off their lists in as fast as an hour. All of Huluville, East, West, South, and North, could order gifts up until 5 p.m. on December 24th. So this holiday, just do as the Who's do. With gift delivery this fast, they all gasped. From Walmart? Who knew? Subject to availability, terms and fees apply.
Hilton stay, oh Hilton stay. Your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh Hilton stay, a holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
And as I promised, we get one more question here from Hematology, question 3. And this is a 60-year-old man with a history of type 2 diabetes, hyperlipidemia, CKD stage 3. Oh, and is admitted to the medical ICU. All right, could use my critical care skills, everyone. Here we go. And went to the ICU for what a surprise, the most common cause of shock, septic shock. Patient remains hypotensive with systolic blood pressure below 90 despite IV fluid resuscitation. And then was started on Levophed, which is the brand name for norepinephrine, which is the pressor of choice when you think about septic shock. They place a central line above the diaphragm in the left IJ. Sure, but you know what? I'm going to wear my critical care hat. You know where I like to place my IJ? In the right, because it's a straight shot right down. It doesn't have to cross the midline. So whatevs, they picked the left, but at least it's above the diaphragm. They didn't put it in the femoral, So soon after the placement of the central line, the patient's left upper extremity is swollen and tender with some +2 pitting edema. They do an ultrasound of the left upper extremity, and what a surprise, there's a DVT. So my little teaching point is, remember, not all DVTs have to be in the leg. If that was the case, they'll call those LVTs, leg vein thrombosis. But DVTs can happen where? In any deep vein in the body. And not a surprise in the upper extremity, because that's where we put all these lines, central lines, PICC lines, dialysis catheters. So we do see this quite often in the medical ICU. Patient has no history of previous DVTs. What is the next best step in the management of this patient? There's 5 choices. Choice A is start the patient on low molecular weight heparin, Lovenox for 3 months. B, start the patient on low molecular weight heparin, Lovenox indefinitely. C, start the patient on low molecular weight indefinitely and switch to rivaroxaban, brand name Xarelto. D, start unfractionated heparin and bridge to warfarin for a total of 3 months. Or E, start unfractionated heparin and bridge to warfarin forever, indefinitely. So let me just kind of do this with you guys, and let's see if we get the right answer. So choice A, start the patient on low molecular weight heparin, Lovenox. Already, wrong answer. Why? Anything that says Lovenox or low molecular weight heparin, Lovenox is the brand name, you can't do it because of the vignette. Patient has a history of what? You nailed it. CKD stage 3. Now, would it be nicer if we put what the GFR is there? Of course, I know they didn't, but you want to associate people who have acute kidney injury, CKD, chronic kidney disease. You want to be careful. You just want to be careful in using low molecular weight heparin. But this seems to be more chronic in nature, and I can tell you one thing: if they're hypotensive in the medical ICU, that kidney function's going down. That GFR is getting lower and lower. So for many reasons, I assume that this is not the time to give a drug that's dependent on having good kidney function. So anywhere in the vignette it says low molecular weight heparin is the wrong answer. So A is wrong. B, once again, low molecular weight heparin, wrong. But also on that, it says indefinitely. And you're not going to anticoagulate when someone has a provoked DBD indefinitely. So for many reasons, B is wrong. C, once again, low molecular weight heparin, wrong, indefinitely wrong. So it keeps on going, and I wouldn't switch to rivaroxaban. If you really wanted to treat it, you could just start rivaroxaban by itself. You know what I mean? That would have been totally fine. But once again, I'm not really excited about any of the DOACs in people who have renal failure. D, unfractionated heparin, very reasonable, because the patient has, acute kidney injury on top of CKD. And then they're in the ICU, so unfractionated heparin, easy on, easy off if you need to put more lines in the patient. And of course, it's a continuous IV drip. You can't discharge the patient home on unfractionated heparin. So I like the bridge to warfarin, you know what I mean, in this case. And then just a total for 3 months. That sounds exactly right for a provoked DVT, one from a reversible cause. So I like choice D quite a bit. Choice E, start unfractionated heparin and bridge to warfarin, but forever? No, it's not going to be forever. So this is a really nice question that I guarantee is going to be on your USMLE Step 2. The right answer here is D. Why? Unfractionated heparin, because patient is CKD with an AKI on top of that. And the fact that it said 3 months duration and it was a bridge to warfarin sounds perfect. And with that being said, I hope everyone enjoyed today's 3 questions. Please check out our website, medprep2go.com, and that'd be great. Follow me on some social media, and I'll see you guys again for our next set of questions.